Welcome to the latest series of the podcast Medical Evidence Matters with me, Liz Tucker, the podcast aimed at doctors and patients. This week, I'm talking to Professor Tony Avery, who's the National Clinical Director for Prescribing for NHS England, and has a particular interest in the safer prescribing of medicines. In our conversation, he discusses the changes he would like to see to enable patients to make genuinely informed decisions, which may also sometimes mean that they decide not to go ahead with the treatment. Tony describes how he believes doctors and patients can work together on initial prescribing decisions so that patients can be confident that the benefits of the selected approach outweigh the risks. But before we get to Tony's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com or via PayPal on my website. A huge amount of work goes into both the research and production of this podcast, so even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. And now back to Tony's interview. Professor Tony Avery, OBE, is the National Clinical Director for Prescribing for NHS England and the National Institute for Health Research Senior Investigator. He's also a GP and Professor of Primary Healthcare at the University of Nottingham. Here's Tony's interview. So, Tony, thank you so much for joining the podcast today.
Thank you. It's great to be here.
So I think, Tony, it would be a useful place to start if you could explain how you got into your current role with NHS England.
Yeah, so my role in NHS England is National Clinical Director for Prescribing, with a particular emphasis on trying to address overprescribing of medicines. So prescribing of medicines where actually on balance, they may be causing more harm than good, or they may not be any longer of benefit to patients. They may have been benefit in the past, but perhaps not so much in the future. That role came about as a result of the National Overprescribing Review, which was commissioned by the government a few years ago, which identified, like a lot of countries, medicines do lots of good, but actually the extent of overprescribing, and particularly for certain types of medicines, or there may be points in people's lives where medicines' risk of harm may be greater than benefit. So in terms of myself coming into that role, I'm a GP, practicing GP, and I'm also an academic. I'm a professor at the University of Nottingham, and I've had an interest in medicines throughout my academic and clinical career. So that's what I've focused on with my research. My research is particularly focused on the safety of medicines as we prescribe them. And so when this role became available, I just felt it was a great opportunity for me because that really fitted with my interests.
When people think about overprescribing, one of the areas they tend to look at is some of the drugs used to treat mental illness.
Yeah.
In particular, drugs such as the SSRI drugs. And particularly when you look at the number of people who are taking those drugs, it does seem a surprisingly large percentage of the UK population.
Yeah, so we have 1 in 5 adults in the UK population who are taking antidepressant drugs. And the advice from the National Institute for Health and Care Excellence, or NICE as it's known as in short, current advice is that we should be, or clinicians should be looking when people come with mental health problems in terms of the severity of those problems. And the advice is that for people with less severe problems, we should be considering alternatives to medicines for most of those people, whether that be talking therapies, but it could be a range of other things, including exercise and social prescribing. Not to say exclusively we shouldn't use them at all. And so I think that's a good example of where we just need to be trying to get the sort of balance right. It can be the easiest thing to sign a prescription, but it can also not be necessarily the best thing for patients, and not necessarily always the safest thing.
Well, one of the things that puzzles me when I look at those drugs, Tony, if you look across the data, and given that in the UK we are evaluating drugs to see if they're going to be clinically effective, when you look at the data, it suggests that on average, the difference between a placebo and an SSRI drug, for example, is around 2 Hamilton points. Hamilton points are often used to measure the level of depression. And typically it's said that you need around 5 points for a doctor to be able to spot the difference in a patient's well-being. So actually the clinical data doesn't seem that strong.
Yeah, and I think it's surprising to clinicians because I think our experience is, and my experience over many years, is you see people with depression, you prescribe antidepressants, you see them a few weeks later, and often they seem to be improved. But the trial data would suggest actually quite a proportion of those people may have improved anyway. And in fact, since I've been prescribing antidepressants less in recent years, taking account of the evidence, it has been quite, not necessarily surprising to me, but it has struck me that when I have that follow-up interview with the patient a few weeks later, having not prescribed antidepressants, they describe themselves as feeling quite a bit better. So, something has happened in that meantime, and it may be partly that they've had the opportunity to talk. Often what GPs do is dismiss, but I think it can be quite helpful, that discussion with patients, and then sometimes it's giving people that opportunity to talk things off their chest, to make them aware that various options are available to them. So we'll often, in addition to the possibility of antidepressants, be talking about other things such as talking therapies. But sometimes people just feel they need a bit of time, and sometimes that bit of time to almost come to a decision as to what, if anything, they want to do. As I say, it does strike me that a few weeks later you will talk to patients and actually they have, for whatever reason, they've improved over those few weeks. And so you've not actually had to take any specific action. They've not actually had to prescribe a drug.
So is it then that reducing overprescribing is also about educating medical professionals and doctors about the benefits, the risks, and perhaps in some cases they may have an inflated view of how effective some medications may be?
As doctors, we tend to overestimate the benefits of medicines and underestimate the potential risks of harm. And in terms of education, I think it's really important for us. I'm very aware, for example, with antibiotics, there can be the evidence and you can hear the evidence, but you've got to believe it. I remember possibly 20 years ago or so, seeing kids with ear infections, feeling like, well, they've got an infection, it needs to be treated. And when the papers started coming out suggesting that antibiotics don't actually make much difference, couldn't believe it, didn't believe it. It didn't make any difference to my prescribing. And then a few years later, a systematic review comes out where they've actually pulled together all the studies, which again is sort of showing these don't make much difference. You have to treat 20 kids for any one of those to benefit. But also the chances of them getting diarrhea actually, or something like that, is actually higher than the chances of them actually benefiting. And the benefit may only be that they have half a day less or a day less of earache. And so it's not until I got to that point that I thought, this is the evidence and I do need to be taking note of it. And I guess that's a similar thing with respect to drugs like antidepressants. It's not to say we shouldn't be prescribing them, but actually we just need to be aware of the limited benefits, particularly of patients with less severe mental health problems.
So do you think we need to reevaluate or perhaps hone further the process by which a new drug is approved or not?
I don't think we necessarily need to do that. I think the most important thing is actually having the information available to the prescriber. So we don't have this for everything, but there's a great resource called GP Evidence produced by colleague Julian Treadwell, and that provides for GPs and other prescribers the likelihood of benefits and sometimes the likelihood of harm in relation to medicine. So what we call number needed to treat. How many people, like the patient in front of you with high blood pressure who happens to be 50 years old and have other risk factors, do you have to treat in order for one of them to not have a heart attack or stroke in the next 5 or 10 years? That sort of information, I think, could be quite helpful for the prescriber in particular, just to be aware of what the benefits are. Say, taking a drug for bladder symptoms, the number needed to treat about 8. So about 8 people need to take these medicines for anyone to benefit. Now, in real life, of course, because of the placebo effect and things like that, there may be a feeling that actually more people benefit. It doesn't feel it's such a high number that you need to treat for anyone to benefit in real life as a clinician. But knowing those sort of figures, then to give a medicine that may have some significant side effects, then make you a little bit more judicious when you're discussing with the patient to convey that sense of this doesn't work for everyone. I would say, for example, with these bladder drugs, if you find it really helps you, then that's great and we can continue with it. If you feel that it really isn't making much difference at all, then it probably isn't worth carrying on with it, and we ought to be considering alternative approaches.
And the other thing I've heard doctors talk about is the level of marketing that they may receive about certain medications. And there was an interesting study, I think, a while ago that said the doctors felt they weren't themselves influenced by marketing, but they thought their colleagues were. It's a bit like no one thinks they are the bad driver.
Yeah, well, I mean, that's the classic thing with advertising, isn't it? So, there's an extent to which when a new medicine comes around, then doctors and other prescribers need to have information on that.
I suppose they need independent information. And by definition, marketing is going to be giving a certain positive slant, isn't it?
Yeah. And that's where, for us in the UK, organisations like NICE are very helpful in their evaluations. In many cases, they are positive in suggesting that we should be prescribing new medicines. In other cases, they're more circumspect about it.
So what is the process, Tony, to decide in the UK if a new drug will be approved or not?
Well, as in all other countries, it goes through a regulator. So in our case, it's the MHRA, or the Medicines Healthcare Regulatory Authority. And before it gets to that point, then the pharmaceutical company needs to do a lot of work. First needs to do the discovery to discover that a particular chemical might actually have an effect, a beneficial effect in a particular illness. It will then do a whole phase of studies, which often can last over a number of years, testing that out in the laboratory, testing it out on animal models, then testing it out in very small amounts in a small population of humans, just to make sure that there's not any serious adverse reaction. And then sort of building that up in terms of trying larger groups of people where you're testing to see what might be the appropriate dose, and then moving on to clinical trials and often very large clinical trials where you can have hundreds or thousands of patients who are randomly assigned to either the medicine or nothing, or in some cases the medicine and an alternative medicine. So it's from that whole real dossier of information that the pharmaceutical company has, which contains information both on the effectiveness and also on side effects, that a regulator such as our MHRA will consider that and then decide whether the balance is reasonable for it to be given a license to be prescribed. Now, in our country, that also involves NICE doing an evaluation of the information, and in particular, it's looking at what's considered the cost effectiveness of the drug, and it looks at something called quality adjusted life years often in doing that. So for the cost of this drug, what benefits are we getting? So if it's a drug to, say, reduce the risk of stroke, stroke's a very horrible thing for people to have, even if they survive it, would be looking at how much does this drug reduce the risk of stroke? And they can then combine that in terms of what are called the number of quality adjusted life years of benefit you get for treating, say, 100 or 1,000 patients with this particular medicine. And then it sort of balances that out in terms of the cost. So for NICE, it's suggesting that the NHS will be willing to pay between 20 or 30,000 pounds per what's called quality adjusted life year gained for giving a particular medicine.
So Tony, would that mean therefore if there's, for example, a breast cancer drug that extends life for a year, if it's between 20 to 30,000 pounds in cost, it would be likely to be approved, assuming it was shown to be clinically effective?
And reasonably safe, yes.
But of course, what happens is drugs hit the headlines when we have these very, very high figures. At the moment, one could think of the Alzheimer's drug. And I think a lot of people would argue that the data is limited for those. But I think the costs, I saw one newspaper article, was suggesting 150,000 a year, which would therefore be way above that figure.
If we've got an effective drug and it's not astronomically expensive, then it is highly likely that NICE will approve it. NICE is often seen to be the bad person in this, but it is evaluating the evidence and coming to a judgment based on what is considered affordable within the NHS.
But clearly a drug that costs, I don't know, 150,000 per annum. If it was a cancer drug and it only extended life for a few months, although as an individual, I can absolutely understand someone would want that. On a societal level, it's just not feasible.
Well, it may or may not be feasible, and I think that's one of the things that needs to be considered. And sometimes exceptions are made. In the Cancer Drugs Fund, for example, exceptions are made for cancer drugs. So it can vary, and particularly for rarer conditions, perhaps. But yes, if you're talking about a common condition where this could be having a very significant financial impact, in a sense, the higher the price of the drug compared to the benefits in terms of quality adjusted life years, the less likely it is to get approved.
And if it's a common condition, the more people will have it. Therefore, it will be that much more costly than a rare condition, which perhaps if only a handful of people have, make it more feasible to pay for.
Yeah.
So when a new drug is rolled out, what sort of information and training do doctors and medical professionals receive?
We don't necessarily receive any formal training because all doctors and prescribers would have their continuing professional development. There are different sources of information depending on the medicine. Then you may well get something come through from NICE. These are things that you're picking up in your everyday reading and listening and looking at journals, discussing with colleagues. So certainly something that's been through NICE and is approved by NICE, then there will be discussions of mechanisms set up. But it's really down to individual doctors and other prescribers to learn about that new drug and look at information themselves. There will be information that comes through from pharmaceutical companies, obviously, and there's the pharmaceutical advertising in many of the journals that we look at. There will be, for some groups of medicines, but I would say it's fairly unusual, perhaps specific training put on where there's something perhaps unusual about this medicine. It might be an injectable or something like this. So there's not a lot of formal education about new drugs. In many cases, it's picking it up. I think there's probably a difference between specialists and generalists here, but certainly for generalists, you're picking up information about this from a range of different sources, which will include the pharmaceutical companies, but balanced with that, what NICE might be saying about it, and then learning about it yourself and picking up on the experience of others.
As a doctor, does it make you more nervous prescribing a new drug? If it's a drug you're familiar with, there'll be a longer safety profile. Inevitably, with a new drug, quite often now we talk about the stage 4 of the clinical trial process being when the drug is actually starting to be given to patients in the wider community.
Yeah, so as a GP, and I think probably most other prescribers, you are going to be more cautious about newer medicines because, we've all seen over the years that whilst most medicines have a reasonable safety profile, then every now and then we discover some serious side effects from a medicine that's perhaps been launched relatively recently and it gets withdrawn from the market. So particularly when you've got an established alternative that you can be using, then I think many prescribers go on the side of caution and will be quite judicious about prescribing the newer medicine, unless there are other things that are particularly pushing us, like, for example, strong endorsement from NICE or NHS bodies.
And of course, an older drug will probably be cheaper.
Often are, yes, particularly if they've come off patent and can be prescribed generically, yeah.
When people use this phrase, stage 4 of the clinical trial process, to describe the initial process when a drug goes into the wider community, do you think patients know enough at that stage that this is seen as an arm of the wider clinical trial process?
It's an interesting point because doctors and other prescribers will be aware that this is a new drug. Patients won't necessarily be aware of that. I guess in terms of the information given to patients, that's an important thing for them to know.
In terms of full informed consent?
Yeah.
So when you've got a drug, both a newer drug and an older one, how do you as a doctor monitor the effectiveness and any potential side effects?
Are you meaning there in terms of a new one compared with an older one?
I was actually meaning for any medication. One of the criticisms some people have made is if there is a problem with the medication, it's quite difficult sometimes to find out that data because, for example, the MHRA then tends to anonymise the reports.
Yeah. Yeah.
So it becomes quite difficult to build up an accurate picture. I think arguably the FDA probably does a bit of a better job on that one.
Okay, so I think it's really important to be aware of the potential for side effects and to have an open mind if a patient presents with symptoms. Sometimes symptoms that you can't imagine being connected with the medicine. A really good example is a class of drugs called quinolones, which are antibiotics. And they've been found to cause tendon or be associated with tendon rupture. You wouldn't imagine that would be a connection. And so I suppose the thing that we're encouraged to do, particularly with newer drugs, almost anything that a patient presents with when they've also taken a new drug is to flag that up through a reporting system such as the yellow card system in the UK. And that means that if enough people do this, including patients themselves, then actually the HRA and other regulators are able to pick up what are called signals that, oh God, this is strange. We're seeing tendon ruptures in relation to this group of drugs called quinolones. We need to look into this a bit more detail, and then that more detailed look would take place. And if it's felt that that link is strong enough, then that would then become, a registered side effect that has to be put down in the product information.
Because I think it could be particularly difficult for doctors, particularly if the clinical trial hasn't identified a certain side effect. The patient might come in and they might check the side effect profile for that drug or the potential risks and think, well, actually, this can't be connected with the drug because I can't see anything on the list.
Yeah. And of course, the important thing to remember there is that even in these very large trials, it may still be the case that 6,000, 10,000 people being in the trial. If a side effect's actually only going to occur 1 in every 1,000 or 1 in every 10,000, it is not going to get picked up, or it's unlikely to get picked up in those initial studies. And that's why what we call the post-marketing surveillance, the work that's done after a drug has been licensed and launched is very, very important. And why it's very important that prescribers and also patients report anything that they think might be connected.
And of course, it also depends on the trial design, because some clinical trials may be designed to pick up a certain percentage of side. So something has to occur, say, more than 5%.
Yeah.
For it to be identified. There's all sorts of things which might mean that early on, there's unlikely to be the full safety profile, which is why we have the post-marketing process.
Yeah, yeah.
I remember a doctor saying to me, if possible, always take an old drug. Do you think that's good advice?
Generally, as long as the old drug is reasonably effective and reasonably safe. From my perspective as a GP, we're in a better position than we were when I started as a GP, in the sense of, most of the drugs that we are using have got a reasonable safety profile, whereas there were some when I started that really haven't got a very nice safety profile.
Now, one of the issues with safer prescribing is the fact that people tend to often now see different GPs. And there was a study, I think, a while ago that suggested that actually if you see your same GP, it actually extends your life on average by around a year. So is there a role for more continuity in healthcare?
I think continuity is very helpful, particularly for people with long-term conditions. I'm aware of the literature around continuity.
Because it's got harder and harder, hasn't it, to see the same GP?
It has, and I think that's because there hasn't been the growth in GPs that there needs to have been in terms of the population growth. When I started as a GP, I think there was one GP per 1,700 patients. We've now got one GP per 2,300 patients. So, and the whole of medicine has become much, much more complex during that time. We, as GPs, treat patients with much more complex problems. When I started, then nearly all the diabetic patients were managed by the hospital, quite a lot of the heart failure patients, etc. Most of these people are being managed by GPs now. So there's just so much more for us to be doing than there was 30 years ago. And so that means that we just haven't got the capacity to see everyone for everything that everyone might want to see us for. The emphasis, I think, in recent years has been on prioritizing access, prioritizing, making sure people can actually see a doctor or other healthcare professional.
Well, I suppose playing devil's advocate, a lot of people would argue that is a fail because so many people now feel, particularly post-COVID, that it's actually harder and harder to see their GP. And if it's not an emergency, certainly where I live in London, people can wait 3-4 weeks quite easily to see a GP.
Yeah. We need more GPs. I think the government and NHS England is starting to do something about this, but it's going to take time for that to come through in terms of training those GPs and getting them out into the system. But, there is good evidence that strong primary care is associated with better health for populations. So it's the way it's being discussed in the 10-year plan for the health service to have greater investment in primary care and in general practice. So I could just hope that we could turn the tide on this, and in particular to ensure that those people who I think would really benefit from continuity, particularly people with long-term conditions, older, frail people, actually get that.
If you look, I think, in primary care, I think it's approximately 10% of the drugs budget, certainly, is going on treating diabetes type 2 alone.
Yeah.
And a figure which appears to be rising. Yet there is now good evidence that with diet, lifestyle, for many of those patients, particularly if you catch them in the early stage of disease, you can avoid that drug route.
Yeah.
And there must become a point, Tony, where diabetes management is going to crash the NHS.
Well, I don't know whether it will crash the NHS or not, but I agree with you that certainly where patients are willing to go along with this, then those sort of lifestyle changes, particularly early on, can make a difference. And, the NHS has invested in programs for identifying people who are what we call pre-diabetes or just at the cusp of developing that diagnosis, to try and make sure that they make those changes. I think the difficulty is it is difficult for people to make the changes, but nevertheless, as you say, there is evidence that it can be helpful. So alongside all of the medicines, which are having benefits, they are making a significant difference.
But if you go back and you look at, say, something like the Concord trial, which looked at detailed intensive management of diabetes patients, it caused quite a furore when it came out, because actually it suggested that long-term intensive management actually increased mortality and morbidity. And I suppose what I would argue is if a diabetic patient goes in and they're given the full facts, that you can go down potential drug route, but there may be complications. And certainly in terms of lifespan, it may well have an impact, as opposed to a dietary and lifestyle route, which could mean you would live a normal lifespan, potentially without other problems. I mean, I'm thinking, for example, I'm sure you'll be familiar with the work of GP Dr. David Unwin.
Yeah. No, I mean, I think that if people are prepared to go along with it, and it then requires skilled practitioners to be able to get people on board with what is a very difficult thing for a lot of people, which might include losing weight, doing more activity, I think it could make a really big difference. So I would agree that would be where you'd want to go first, particularly with patients who are presenting early. My experience with, many patients, despite that advice, don't lose weight, don't change their lifestyle a great deal, and therefore we are predominantly relying on medicines. But it's also worth saying it's not necessarily an either or. Obviously, there will be those people who manage to reverse their diabetes by changing their diet and lifestyle, which is great. For other people, they may not quite be able to do that, and therefore a combination of lifestyle changes and medicines may be helpful. I think one of the things I also say in terms of diabetes is actually think about the cardiovascular risk. So there's one thing about, how tightly you control their blood sugars, but there's another thing about recognizing that these people, are at risk of long-term cardiovascular problems, heart attacks, strokes, etc. And that's where considering some of the various different types of preventive medicines can be very important.
I mean, presumably for reducing overprescribing as a whole, lifestyle changes are going to be key, not just in diabetes, but for a range of conditions.
Yeah, I think it could make a considerable difference. So, I'm positive about it, but I just recognise there's the challenges, and it's not all down to the health service. It's down to a whole range of other factors.
It's not a quick fix. They might have to start exercising. They might not be able to eat jammy donuts every day or whatever else it happens to be.
Yeah.
So if we want to promote safer prescribing, less overprescribing, how does the use of digital resources fit into this?
Well, I'm thinking digital resources, particularly thinking in relation to what we have available as prescribers. Most of our prescribing is certainly general practice. It's almost all done through computer. In most hospitals, it's now done through computers. And there's evidence that computerized clinical decision support can be helpful in improving safety. It's an area that I've studied quite a lot. There are issues in terms of how well some of these systems are designed. There's the issue about trying to get the balance right between the number of alerts you get and not getting what we call alert fatigue and the so-called cry wolf syndrome, where you've just been alerted so many times that doctors and other prescribers could get used to just clicking the override button. But, I try to encourage myself and colleagues to make sure we do at least have a glance at these messages that come through to us. So that's the one thing. The other thing is actually making use of the fantastic electronic systems we have in order to identify patients who may be already on medicines but at risk of those medicines. So sometimes it can be as a result of an alert that's come through from the MHRA saying there's a particular problem with a certain medicine. So the fact we've got our electronic systems means we can identify these patients, but also then, when evidence comes about that, certain combinations of medicines is hazardous, or there are other circumstances where medicines are hazardous, we can run searches to identify these patients to then try and correct the problem.
Because that could be really difficult. What's called polypharmacy. We don't have trials to tell us what a particular mixture of drugs will do. So we're really reliant, particularly on GPs, because you see more patients than anybody else, in terms of basically collecting that data, and also because GPs tend to see patients over a longer period of time, and sometimes those effects accumulate.
Yeah, so you're right that we don't know the full effects of people being on lots of medicines. I mean, there is a sense that there are some groups of medicines. So, like, for example, medicines associated with protecting you from cardiovascular disease, that they do seem to be working synergistically and generally in a positive way. But, by contrast, when you've got people on multiple psychotropic drugs for mental health problems and analgesics, things like opioids, then, that combination does not seem to be such a good thing. People who are on multiple medicines, what we call anticholinergics, which can cause dry mouth and things like that, but more serious side effects, are not such a good idea. And then there can be combinations of medicines that may, for example, increase your risk of a gastric bleed, or may increase your risk of kidney injury. So these are all things that we need to be alert to. They're all things where having good computer systems could be helpful in either identifying those patients when we're doing a medication review, or for us to be doing searches on our systems to be flagging up the patients where, their risks from their combination of medicines may outweigh the benefit.
So if you could wave a magic wand, what structural and cultural changes would you make to the NHS to encourage and promote safer prescribing?
I thought about this quite a bit, and I think it'd be one that feels a bit at the basic end of things, but it's what we often call BRAN, which is a mnemonic for what to think about when considering prescribing.
And what does BRAM stand for?
So BRAN stands for considering benefits, risks, alternatives, and what if we were to do N nothing. To have time, that initial prescribing decision, to really go through that for both the prescriber and the patient. And ideally, unless it's a really urgent problem, for the patient actually to be able to go away and consider all those things themselves, the information they've got on how likely I am to benefit from this, what are the risks of me taking it, what are the alternative things that we could do. When we say doing nothing, it's usually not doing nothing. Sometimes we talk about it watchful waiting, but sometimes it can be worth just giving things time, as example I gave earlier with people with mental health problems. Sometimes just given a bit of time, things improve. I'm thinking there are very few major purchases that we would make, if we're thinking of buying a car or a washing machine or a new mobile phone or something like this, that you just make on an immediate decision, that you just go into a room with someone in a 10-minute discussion and then come out and say, yes, that's the car I'm having, or that's the washing machine I'm having, that's the phone that I'm having. Most of us would go away and consider the information, do all sorts of things in sort of sourcing other information, seeing what other people think before coming to that decision. And I think if we could be moving more in that direction with decisions around medicines, that could be one of the most important things we could be doing, because we want to be making sure that when we prescribe medicines, they are the right medicines for people that people want to be taking, that the balance of benefits outweigh the risks. So I think that would be one thing which I think could make quite a big difference. But it's making sure we've got the time and resources to do that.
And some doctors are very receptive to their patients, perhaps doing some research themselves, because particularly if the patients have an unusual condition, they can almost become experts sort of in their own conditions. Whereas other doctors will say, the last thing you should do is look at Google.
Yeah, I'm in the first camp. It's people's conditions, it's people's lives. I accept that you can get the wrong end of the stick from Google, but generally my experience is that when people report things that they have found, then it usually makes sense and it helps in terms of the consultation and the decision making. And if it is something that is off beam, then you could explain that to the patient. So overall, I just feel that the more engaged and informed patients are, the better. And it is ultimately their health, at the centre of this.
Nobody's going to care more about their health than them.
Yeah.
But do you think patients also have a responsibility? Because if a patient goes in and they sort of want something done, then the GP thinks, oh gosh, I better do something. Whereas if the patient went in and didn't feel in that way, perhaps the GP might feel less of a pressure to do something immediately.
GPs I speak to, can feel under pressure. We talked about antidepressants and alternatives to depression. Antibiotics, I just feel we've perhaps made, certainly in our practice, more progress on. It's quite rare to have people coming in demanding antibiotics. I usually have one coming for a discussion about the pros and cons. But, it's not unusual, for example, if someone coming with mental health problems, and you could be pointing out all these other things, the talking therapies, I could refer you to this or refer you to that. And some people will want to opt for the medicine. So, that is it's a challenge if we're being patient-centred. Obviously, that's the way we go. But equally, you want to try and make sure that people are as informed as possible, that they are making the best decisions. And again, that perhaps fits with making sure that you've got resources like we have for quite a number of things. For example, NICE and NHS England have got a resource for help for people to consider all their options when thinking about what to do in relation to, say, depression. A patient to go away and consider all that before then coming back and saying what they've decided on.
So if we speak again in 5-10 years' time, what do you hope will have changed?
I hope we've got more GPs, so that actually patients have got better access to GPs and other healthcare professionals in primary care, so that there is the time and more time for discussions around medicines and their alternatives. I hope and think we're going to see some improvements with the resources available to patients, an ambition in the NHS plan. We're going to see further improvements in the NHS app, which I think is already good, particularly around medicines.
I was going to say with the NHS app, and I just know from elderly relatives who are not so keen on the internet, even those who can use it to some level, that they really struggle if too much is online.
Yeah. I accept that's the challenge for some or many people. I'm also really amazed at patients of mine in their 90s who manage it. I think they're putting as much time and thought into the design of the app to make it as user-friendly as possible. I think and hope we will see improvements in that. And I think another area I'd like to see improvements, and I think there's a direction of travel here, is making sure that we've got a single source of information about people's medicines, and you're not in a situation where you go into hospital and the hospital hasn't got a clue what medicines you're taking or needs to be ringing the practice. That information is sort of held centrally, so we have a sort of single version of the truth.
Well, Tony, that's really useful. Thank you so much for speaking today. Really appreciate it.
Brilliant. All right. Thanks, Liz.
Goodbye.
Cheers. Bye-bye.
Hope you enjoyed the latest episode of the podcast. And if you've enjoyed the podcast, if you could share it and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. Many thanks for listening. Bye for now.